Welcome to your board review courses. We are going to discuss today humerus fractures. The topics for discussion will be proximal humerus fractures, humerus shaft fractures, and distal humerus fractures. Let's start with the proximal humerus fractures. I think we all know the Neer classification, which talks about 4 parts for the humerus fractures. The 2-part, 3-part, and 4-part, each part being tuberosity, shaft, and the humeral head. Remember, fracture dislocations are also included in this classification. Unfortunately, even though this is a very commonly used classification, it has very poor inter and intra-observer reliability. The important thing to remember about the humerus is blood supply, which, as you can imagine, is tenuous at best, with a predominant blood supply coming from the anterior humeral circumflex artery with other small branches. Indications for surgery, again, for your boards, things that you need to know. Parts being displaced more than 5 millimeters. This applies to greater tuberosity more than anything else. The angulation of 45 degrees, which applies to the head compared to the shaft. There is a risk of AVN of the humeral head based on the displacement of the fracture. Presence of medial 4 millimeters of calcar is protective from AVN, as seen in postoperative X-ray studies. Indications for surgery, 2-part fractures or 2, 3, or 4-part fractures, especially in the young patients with bone quality. The standard of care today has become use of locking plates, which have definitely changed our operative methods and indications. Replacements, these are usually reserved for 3 and 4-part fractures or fracture dislocations in the elderly with poor bone structure. The approaches that we use are one of the two, the most common being the deltopectoral approach, which again is a very familiar approach. It allows for open reduction, internal fixation, or a replacement. It does make it difficult to reach the greater tuberosity, which is displaced posteriorly. The lateral or the deltoid split approach is much more useful for this part, which is reaching the greater tuberosity. You do have the risk of axillary nerve injury, which is about 5 centimeters distal to the acromion, and you cannot do a replacement should you change tack at this point. Complications include malunion, hardware penetration to the articular surface, avascular necrosis, which we talked about a little while ago, and heterotopic bone, which is secondary to the extent of injury to the soft tissue. The way you want to avoid most of these complications, but not all, is to get an anatomic or as close to anatomic reduction. Definitely do not reduce this in varus. Identify all the fractures so they can be appropriately fixed, and then do multiplanar fluoroscopy to confirm that there is no articulation. Outcomes can be good to pretty good, especially 1-part fractures should have excellent outcomes as long as you start physical therapy or mobilization early. If you send them for PT within the first 2 weeks, as been shown by studies at our institution, they have a very good outcome. For 3 and 4-part fractures, the outcomes will be better in the elderly with a reverse shoulder arthroplasty. Point to remember for your boards that the results of a reverse shoulder arthroplasty for fracture now approach those for primary shoulder arthroplasty. Example is this 4-part fracture dislocation. Before we talk about the treatment for this one, I want you to just understand that humerus fractures can do reasonably well as long as you manage expectations of the patient. A patient with limited goals may do very well with non-operative treatment, even though there may be radiologically indicated for surgery as seen in this patient. And this is a reverse shoulder arthroplasty done for the previous patient who proceeded to do pretty well with 120 degrees forward flexion. The trend in proximal humerus fractures, as you will see from this slide, has moved away from partial replacements. So hemiarthroplasties are becoming rare. More commonly, we are doing a lot more fixations thanks to locking plates, and a lot more reverse shoulder arthroplasties in the elderly patient. So that was proximal fractures. Now let's talk about humerus shaft fractures. They represent 2 to 3% of all fractures. They range from low energy to high energy, a classic bimotor distribution. And most of the fractures are actually managed non-operatively in a functional brace, which can be applied as soon as the day of injury in the emergency room. It allows early range of motion of the shoulder and the elbow. Functional bracing has a limited morbidity, allows early range of motion, and the humerus is excellent bone to treat non-op in the sense that there is a wide range of deformity that is well tolerated. And you need to remember these angles: 20 degrees of sagittal, 30 degrees of coronal, 15 degrees of malrotation, and up to 2 or 2.5 centimeters of shortening are very well rated. Surgical indications depends upon the fracture pattern, obviously, but also other factors like polytrauma, open fractures, vascular injuries, bilateral fractures, floating elbows, pathologic fractures, which are probably not going to heal stabilization. Relative indications, these are not necessarily, well, you have to fix it, but you may think about fixing it in certain patient populations. Patient with paralysis or brachial plexopathies may benefit from fixation because Sarmiento or the functional brace may not work due to lack of hydrostatic pressure that you might generate from the muscle contracting. A large body habitus may exacerbate the malalignment, especially in the varus, and difficult to adequately brace a large arm. Then there are certain fracture patterns that may benefit from surgery, and we'll talk about as we move along with this talk. A fracture like this with a short oblique or transverse with unacceptable reduction in spite of multiple attempts, this underwent fixation using the anterolateral approach. Talking of approaches, the two main approaches for the humerus shaft typically are posterior and anterolateral. You can also do this open or percutaneously. The so-called MIPO approach for the humerus has been shown to have good results, which may be comparable to non-operative care with small incisions with minimal risk of complications. The potential predictors of failure for functional bracing, like we talked about earlier on, are the specific fracture patterns which are difficult to brace. Keep those in mind. Proximal humerus fracture, you can see the obliquity and the pull of the deltoid can cause the deformity, which may be difficult to control even with shoulder extension. Patients also don't like this kind of bracing. Distal humerus, again, we'll talk about that in the distal humerus section, but these have a very high risk of malunion, and younger and active patients may not be tolerant of this malunion. Radial nerve palsy, another controversial topic for your boards. Remember, if the patient has a radial nerve palsy, either at presentation or after reduction, that is not an indication for exploration, as 88% or so will recover without any intervention as shown by Ring. Open fractures probably should be explored because they have a higher risk of associated nerve laceration, so it'd be a good opportunity to tag the nerve or repair it acutely if you have the ability to do so. This is an interesting study that came out 3 years ago, which talked about randomizing bridge plating to functional bracing, and they used, you can see pretty much all of the humerus shaft, and they did multiple outcomes. And what they found, that while the DASH score was better at 6 months, no other time, and the non-union rate was higher in the non-operative group, what they found was there's really no difference in function, and they do not recommend surgery based on this. Let's move on to distal humerus fractures. These are uncommon injuries, again with the bimodal distribution, and the treatment will vary upon the age and the activity of the patient. This is a very complicated and a complex injury with far-reaching effects, which can change the patient's functional status. It does also portend poorly for outcome in that very rarely do patients get full range of motion and function after this injury. There are a lot of challenges with this injury, including the exposure, the artery reduction, presence of comminution, presence of multiple nerves, and the recovery of elbow motion can be difficult. Anatomy, again, this picture has been seen by you guys many times. The columns diverge about 45 degrees from the shaft, and there's also a carrying angle of 4 to 8 degrees. The distal anatomy, the so-called spool of the capitulum and the trochlea, is also complicated because of a significant amount of articular surface with cancellous bone to hold on. Classification, AO classification is the commonest one used. Fractures, again, this is the one we talked about earlier on, the extra-articular fractures. These can be managed in a humeral brace, though the high degree of deformity and in young patients, this may be something that will do fixation with pre-contoured plates or dual plates, typically inserted posteriorly. Indications and principles of surgery, again, like any other articular surface, you want to restore the articular incongruity and create one articular block. Once you have an anatomic articular reduction, then you can restore the column length and axial alignment, and then you fix it stably. The approach, multiple approaches, but mostly posterior. You may require an olecranon osteotomy or a triceps splitting or reflecting approach. This example here shown is a triceps reflecting on, this tricep reflecting or so-called para-triceps approach on either side. The triceps is not detached, left in place. You can see a fair amount of distal humerus, however, the articular surface visualization is pretty limited. Medial and lateral approaches are typically reserved for unicolumnar fractures or capitulum fractures. The basic principles remain the same. You restore the articular surface. You can use multiple screws, whether headless or headed screws, and then you want to reconstruct it to the columns, and you want to fix the less comminuted column first. You can use small mini fragment plates to reduce this provisionally, and then put the pre-contoured column plates to fix the fracture securely so as to allow early range of motion. Total elbow replacement is usually reserved for the elderly low-demand patients with compromised bone stock, possibly pre-existing arthritis, whether osteoarthritis or rheumatoid arthritis. These advantages of doing a total elbow replacement is that you can allow early range of motion. Downside is that the patient has a lifetime restriction of how much weight they can lift. That's anywhere between 5 and 10 pounds based on the study you read. Complications, again, a litany of them, of predominantly being elbow stiffness and heterotopic ossification. The olecranon osteotomies have their own complications of hardware prominence, need for removal of hardware, even non-union, and some series the risk of osteotomy complication is as high as the risk of distal humerus complications. Ulnar nerve transposition, again, another controversial topic is whether it helps or does not help. And typically, ulnar nerve transposition has made no difference in multiple studies, including one from our institution. So it's essentially surgeon preference. Capitulum fractures are unique in that there is that they are missed on an AP view. On the lateral view, you can see the double arc sign, which lets you identify it. These require a lateral approach.